Thank you for joining iMeet.
And then meeting 6, we will have not the final
This meeting is
sustainability
now
plan,
being
but there will
recorded.
be a discussion and presentation of what we have to date. Again, we expect this to be a living document. This is a starting point. There's lots of work to be done in addition to collaborating with other initiatives that are happening across the state. So to summarize, key factors and strategies that contribute to program sustainability. This comes directly from the National Council on Aging, from one of the fact sheets that I've referenced below. As you see the different elements of sustainability, today we are focusing on financing and looking at ways of diversifying funding streams, incorporating objectives and strategies and action steps that will be incorporated into our sustainability plan as the business section of our plan. So what does CDSME cost? We are basing this cost analysis on the Self-Management Resource Center, which I described at the last meeting, has changed from the Stanford University Stanford Patient Education Resource Center. They're transitioning to the Self-Management Resource Center as a separate business entity. It's the same staff, same program. Kate Lorig is still heading up the team, and we're basing the cost analysis on this chronic disease self-management education model. So the Self-Management Resource Center costs are relatively controlled and stable, and I'll describe that in a little bit. And these are based on evidence-based curriculum with well-demonstrated outcomes that we will also show you in just a moment. So just to recap, for those of you who were not on the call last time or just need a refresher, the Self-Management Resource Center evidence-based programming model is endorsed by the National Council on Aging and the Administration for Community Living. It is evidence-based. All of the programming builds upon their base program, the Chronic Disease Self-Management Program. It requires, it must be delivered under a license, which is 3 years in length, and we have several licenses throughout the state. We'll talk about them next week. It is run essentially by master trainers, who are the individuals that are trained by Self-Management Resource Center certified T trainers from across the country. These master trainers then supervise and train lay leaders within our state. Workshops are delivered through a 6-week series. They're 2.5 hours each session, once a week. We cannot change that model. Again, that is the evidence-based structure. Workshops are co-facilitated by 2 trained lay leaders. Depending on the disease state, we're talking about diabetes. One of them would have to have diabetes or be a primary caregiver of a person with diabetes. So if it were the chronic pain model, it would be one person living with chronic pain or someone providing primary care to someone living in chronic pain. And chronic disease, that's probably the easiest one to meet. That could be anything from depression, pain, arthritis, diabetes, any chronic condition that you can think of would fit in that, would qualify. The programs, the workshops are delivered with the fidelity standards, which provide quality assurance. It's the responsibility of the master trainer or the assigned program coordinator, if it is not the master trainer, to conduct that fidelity assessment according to Stanford Self-Management Resource Center's fidelity standards. There is a whole manual that outlines fidelity that's very lengthy and detailed, so there isn't really any way around delivering this program according to the evidence-based structure that was designed. Workshops are conducted with an ideal participation rate of between 10 and 16 participants. Again, this is the recommendation of a minimum of 10 by Self-Management Resource Center and ideally a maximum of 16 participants, because it is extremely interactive and engaging with action planning and discussion groups that happen throughout the 2.5 hours. So we presented last week on the materials that come along with the program. We can't use miscellaneous handouts. All of the resources that the participants receive are the evidence-based manual as well as either an exercise or a relaxation CD. So let's talk about what the workshop cost is. Before I go on, are there any questions? Again, use your chat box to ask questions. We have someone monitoring that, or unmute your phone and ask your question. Okay, so this is not a fully, and I'll show you in a moment how we can calculate the true cost of programming. This is just a snapshot. So when we look at what it takes to conduct workshops, the base license is about $1,500 for a 3-year period of time, and that is to cover 100 workshops and 6 lay leader trainings. If we go above and beyond that under one license, then we just pay more. I must have them on auto advance. We pay more for those additional workshops. So when we break it down according to having 10 people in a workshop on average, that cost per person is about $1.50. Per workshop, it comes out to be about $15 a workshop if we look at using the maximum of 100 workshops. The other resources that are required, and again, this is all through the Fidelity and Administration Manual that we obtain the requirements to deliver workshops. And this doesn't matter, it doesn't matter which type of workshop you're offering, whether it's diabetes, chronic disease, chronic pain, all of the materials are similar. So there are flip charts. Stanford Self-Management Resource Center does not want any kind of digital electronic resources used. So we can't use PowerPoint. We use flip charts. Everything is handwritten because that is the way it was tested and modeled and is most acceptable to the peer groups that are participating. So there are flip charts. There are cling sheets that stick to any wall or surface, including people. They're written out in advance. The flip charts are there are flip charts that allow questions to be taken, a parking lot, as well as to record information that the class shares. There are markers that are required, reusable name tags. Other expenses would be travel to the site, and again, this would vary. If there's room rental, usually we try and get host sites to give us, donate the space, but if not, there may be a charge there. And of course, there's staff versus volunteer time. So I just provided an estimate for what it would cost for staff time for the 6-week session. And that would be based on if there were a staff person and then a fully volunteer person. So we can estimate about $600 a workshop. Again, this is not calculated in depth. This does not include the cost of master training, liability insurance, organizational overhead, marketing, etc. Other cost implications would include sites for delivering the program. As I said, if they were not available for free, we need funds to purchase program supplies to support staffing, lay leader training costs. Sometimes organizations will provide meals or snacks as a part of the lay leader training. The lay leader training is between a 4 to 5 day training, depending on if there is a cross training. All lay leaders, if they're going to be conducting chronic disease self-management plus a specialty like diabetes or chronic pain, have to be trained in the baseline chronic disease self-management programming, and then participate in a cross training, which is somewhere between half a day and 1 day, up to a day and a half. So there could be travel costs that might be covered. There are duplication costs as a part of the lay leader training. There's data collection and coordination, as well as marketing, promotion, and participant recruitment, which would be staff resources. It may be paying for marketing and promotion, maintaining a website, those types of things. And then developing that integrated sustainable delivery system that we will talk more in meeting 3. So let's take a look at the program cost calculation using the model that's been developed by NCOA, the National Council on Aging. So I've provided the link. There is a CDSMP cost calculator tool The link is at the top. There is a webinar. If you so choose to listen to it, I would encourage all of you to do it. If you are so interested, it goes through the details of how this calculator was developed and how to use it. The tool contains 3 tabs, actually 4 tabs: a welcome, program data, training, and summary. So if we look at the first tab, and this would be a download. So if you go to that original link at the top there, there are several downloads that you can take, including the actual cost calculator tool, which is an Excel spreadsheet that has automated calculations, and you'll be able to see what that looks like in just a moment. So there's a welcome page on the first tab that provides some details. If you were looking at this live, there at the very bottom there would be a start date and an end date for looking at your cost calculation. This is the program data tab, the second tab in the Excel spreadsheet. It includes personnel and program administration, including all the direct and indirect costs that you can imagine, marketing and recruitment costs, what it costs to deliver the CDSME workshop. Some of that information we've already gone through, as well as master training costs. The training tab goes through, and again, this is just a snapshot. You can see at the bottom the 4 tabs. This is the training calculator, so how much we're utilizing current training in terms of workshop, leader training, and then there's the training cost manager and how much it costs based on class size and things like that. So all of these are variables, and as I described earlier, we can get a very detailed and accurate picture of what it costs to run these programs. And this, as you see, will be individualized based on where this program is being offered in the state and who is leading the workshop, if it's a staff person or volunteer. And then it provides, from all the variables that are entered in, there's a summary that is provided so that you can really see basically your inputs and your outputs and your cost budget for delivering these workshops. So one of the things that we will be asking the Leadership Sustainability Group is whether or not this is something we want to build into our sustainability. Do we want to provide technical assistance to work through these spreadsheets with partners so that they can go through this detailed assessment and have a true, accurate picture of what it is costing to run programs, or if you have other recommendations on how to utilize this information. We welcome you to put any questions that you have in the chat box at this time, or record them on your own to then email to us or to provide through the follow-up survey. So let's take a look at return on investment. What are the healthcare cost savings? There's lots of research. And if we look at the AAA model, which NCOA utilizes and promotes as a part of justifying where CDSME falls into the healthcare landscape. So if we look at the AAA model, and I did put the link at the bottom if anyone needs to get more information about this, the main AAA model is, AIM model is the triangle. So we have population health, the experience of care by the patient, and then per capita cost. So we're looking at improving overall population health. When the patient experience improves, impacts all of the other components in the model. And then we see an overall reduction in the cost of healthcare per person. And these are all the inputs. So we see individuals and families. We see the impact of improving primary care. We look at the integration of services across the spectrum from healthcare, social services, public health. We look at what is happening with individuals and what the cost of healthcare is per person, as well as prevention and health promotion efforts, which certainly chronic disease self-management education programming falls. And then there's the ongoing data systems that demonstrate the impact of these interventions and impacts. So we're really looking at quality of healthcare and where CDSME falls in this spectrum. So this is some research, results from the research from the CDSME National Survey that was conducted between national studies. The results are from 2010 through 2012. There was one study that marked 6 months and then 12 months. So we are well past, of course, the 12-month mark. So there's lots of analysis and data from this. So when we look at what the savings is, we save approximately $714 per person when we look at the reduction in emergency room visits and hospital utilization. There's an overall savings per person, even when we consider the program cost per person of $350 that has been assessed by the Self-Management Resource Center. When they extrapolate out, and I'll show some diagrams on how some of this data is extrapolated, there's an estimated $65.7 billion in savings if we can reach all individuals with chronic conditions. And then even if we can just reach 5% of individuals with chronic diseases, we can save a potential of $3.3 billion just by providing chronic disease self-management education. We see improved health, and you can see how this is tying back to the triple aim. Again, here's the 6-month study. We see the reduction in hemoglobin A1C levels. When we look at improvement in behavior, we see a 13% improvement in the number of days a week that people are more active. We see less sick days or unhealthy mental days when people are just feeling down. So we can think about, for those seniors, since we are targeting adults and adults with disabilities, thinking about the working population and how this impacts productivity and at work, as well as a person taking care of themselves. And then we see the improvements in the various symptoms and complications that are specifically discussed during the chronic disease self-management education programming. So fatigue, pain, shortness of breath, stress, and sleep problems. And we know the impact that sleep has on all chronic diseases and quality of life. When we look at the healthcare costs, this was on the earlier slide, we see that 5% reduction in emergency room visits from baseline to 6 months. You see this, it's stable at 13% at 12 months. And then we see a 3% reduction in hospitalizations from baseline to 6 months, and it continues to increase at 12 months. So although this 3% reduction may seem small, again, when we look at the numbers and the studies, the population from the study was up in the thousands range. The literature talks a lot about activation, patient activation, and this is where we go back to the triple aim model, where we look at the patient experience and their care. So when patients are activated, they are more satisfied in their care and are better participants in their healthcare team. So we can see some of the data that's available here that shows the impact on complications. So participants who follow up with their foot exams and kidney function tests through microalbumin tests. We see improved behavior participation through physical activity and increased movement from those who are not exercising, as well as improvement in taking their medication. And if we just think about the impact of that, if people are taking their medication appropriately and having improved metabolic parameters, and possibly have a reduction in their medication utilization, there is an impact on healthcare costs directly. So when we talk about additional data here, doctors want patients who are easy to communicate with. Patients want to feel confident in talking with their doctors, and these are some of the skills that the program specifically teaches. Giving patients the confidence to speak with their doctor about their health condition. So just to summarize the impact on the triple aims, we have patient experience, and we have patients that are better able to take care of themselves and communicate more effectively with their care providers. We saw the decrease in healthcare costs, and when we look at the individual patient experience, improved healthcare, we see improved population health. Any questions, thoughts?
I have a question on hopefully the end.
Okay. So now we're going to get into the healthcare savings calculator. So those were the research studies. There is a model that was created, again, supported by the National Council on Aging, that took the studies and created a mathematical statistical model that goes through 6 steps of calculating the national savings. This model can be utilized at the local level by using real data to then look at what the healthcare savings are locally for us. And it is very detailed. I provided the references here to be able to go back to both the national studies as well as providing the link to the healthcare savings estimator, and here it is. So this is a tool that is available. It was developed at the University of Memphis School of Public Health. We're not going to go through it in detail, but just wanted to let the group know that this is available. And again, we need to make the decision on how detailed we're going to get. I think this would be of interest to everyone. Again, this wouldn't be something that we would be doing now, but would be making the decision about either exploring it further, having more detailed discussion about it to potentially look at in the future as a part of an ongoing process of measuring the cost savings as a result of implementing a chronic disease self-management program. I provided the link so everyone can go back and take a look at their own convenience at this information. So I just wanted to just pull out, since it was mentioned we know the high risk of complications with lower extremity amputations and foot problems in people with diabetes. And, we've talked about some of the costs associated with chronic disease self-management, and sometimes that is an inhibitor of programs because we have to have a staff person that may cost X thousands of dollars per year to support this programming. But when we look at the complications of diabetes and how costly, and this is just one complication, we're looking at $116 billion to treat diabetes and its complications. 33% of that is associated to foot ulcers, which is a staggering amount of money. And then when we look at those people who actually go through foot or leg amputations, the cost can be between $30,000 and $60,000. And then when we look at the post-hospitalization phase, there are additional costs. And then I added in the last 3 bullets, just thinking about the person who has had a foot or a leg, lower limb amputation with the reduced quality of life, independence, risk of other comorbidities as a result of isolation, reduced physical activity, infection, the list can go on, as well as continued pain. So it seems obvious to me that prevention would be the key here, and that's where chronic disease self-management education falls in line. I'll just pause here for a moment for questions. And I would encourage the leadership group to anytime you find any resources or would like to share any pieces of information like this that we could include in the sustainability plan that help just provide and illustrate the extreme cost of not providing prevention and self-management education to our state. So funding strategies. There are several sources of revenue and funding that we can look at. And again, today is not the day to say this is what we are going to do, but to really explore what the possibilities are. So I didn't make this up. This came from the Missouri CDSME Sustainability Toolkit. As you see, the link is below. It is a beautiful document that was created. I can't remember exactly the date. I think it was around 2012. So this information has been compiled by the National Council on Aging. They've done an excellent job of collecting successes, best practices, and stories, and evidence, as you see, and providing this funding. So these are some of the ways that we can fiscally support this programming moving forward. So we always go to the first one, payers, Medicare, Medicaid, private payers, insurers, as well as we're looking at employers being self-insured, or even if they're not self-insured, making the investment because they know that prevention and self-management is a key to reducing their healthcare premiums and improving their workforce health and as well as their bottom line and productivity. So some of these models are fee-for-service, some of them are value-based or incentive-based contracts, and I'll list them in a few slides. I thought the second bullet was interesting. Missouri pulled out the idea of providing discounts and deals to attract customers. And we'll talk more about this in the marketing and recruitment strategies of the fourth meeting. So if we do provide discounts and deals, how do we make up for that discount? So if a AAA or a primary care practice or a federally qualified health center in the community is offering these programs, so we don't have the luxury of discounting co-payments for individuals, but let's say there are self-pay participants. If we offered a discount to those individuals, how would we make up for the difference in covering the cost for continuing to sustain programming? There may be incentives for patients, gift cards, and things like that. So we always need to think about how do we fund those types of programs and deals. We all know very well competitive grants as well as partnering and subcontracting. That has been the way that the Pennsylvania Community Living Initiative has been funded through the Administration for Community Living, funding through the Prevention and Public Health Fund. Looking also at local and foundation funding. So I think that's one area that we could potentially explore as a part of this, and looking across the state and really drilling down to the local venues where these programs are offered, as how can we get additional support from various local funding as well as philanthropic and charitable contributions. We don't want to leave out the potential for fundraising events. There may be the potential for having fundraising events, especially with participants. Often fundraising events are usually held by organizations like the American Diabetes Association to support ongoing programming. So maybe that could be a partnership. So that would be another area to explore. And then certainly, last but not least, we can certainly look at self-pay. Why can't we have a model that is similar to Weight Watchers and Jenny Craig and those types of programs? People pay out of pocket. We know that the weight loss industry is a billion-dollar business. So why are we not using that model as one of the funding streams? This would be a good time for any thoughts, additions, anything that we left out. Can everyone still hear us?
Yes. Yes.
Okay, thank you. When we look at fee-for-service options, there are several options to explore: diabetes self-management training, health behavior and assessment interventions, medical nutrition therapy, and then there is the model for behavioral health care services through Medicaid. And this may be a model that we want to explore in providing support for more of a lay leader type of model or a community health worker model to support this type of programming. So let's take a look at diabetes self-management training as the first model. So hopefully everyone has heard about diabetes self-management education and their accreditation or recognition through the American Association of Diabetes Educators or the American Diabetes Association. These two national organizations are the certifying bodies that are recognized by Medicare, by Centers for Medicare and Medicaid Services. So in order to, for an organization to bill for DSMT, they would have to be accredited or certified. So the Self-Management Resource Center DSMP programs can qualify for DSME certification through these certifying bodies. It takes a little bit of work to adapt, not the curriculum, but the staffing model. But it is possible, and it is one of the efforts that are happening across the nation. There have been several other states that have been successful in doing this. We are working locally with the Philadelphia Corporation for Aging as our partner under the Department of Aging to help us create this model for the state. They will be the first to apply for DSME accreditation through the American Association of Diabetes Educators. So once that happens, we will be creating a toolkit that other sites that are implementing DSMP can utilize to adapt. And looking at, one of the things we do want to look at as a part of the Leadership Sustainability Group is how do we efficiently utilize DSME certification, and what is the best model? Do we look at an umbrella model that we have several partners working in a region with an accrediting body, and then having several organizations partnering with that main accreditation or recognition site as a community site or an expansion site? So there are many different models that we can dive into and take a look at. In order to get reimbursement, the organization that is certified needs to be a qualifying body that can receive a Medicare billing provider number. The Department of Health, through the Centers for Disease Control 1305 funding, Health Promotion Council is working closely with Department of Health in implementing technical assistance and support throughout the state to help with this certification process. So again, we're working closely with Philadelphia Corporation for Aging through that funding stream. There is a website that's available, so I can provide some follow-up information for that in our follow-up materials. And if the leadership group would like to dive into that topic a little bit further, please let us know in the follow-up survey or by email or in the chat box at this time. Any questions? Let's take a look at what this would mean for DSMP. So I already included medical nutrition therapy, which is MNT. The subject matter expert that has been working with organizations across the nation in the leadership collaborative around diabetes self-management training and medical nutrition therapy for sustainable funding has provided the snapshot. So when we look at DSMT, it's reimbursed using two different codes. These are specific for diabetes and not used for anything else. They're called the G codes. 08 is an individual code, and 09 is the group code. The Medicare CMS allows for 1 hour of an individual visit plus 9 hours of group education. And you can see how the billing increments are broken down to give us the totals. So for 1 hour of an individual visit with a person, and this is for the individual planning, goal setting, and working with the person individually to make sure that we're making sure that we're addressing their needs in the program and establishing goals. So when we look at the individual visit, we've got the total. If we took the maximum that we would use for DSMP, which would be 16 patients, would be $1,734. And that includes, I'm using the full reimbursement, so that would be what Medicare would pay plus the 20% of either the patient's copay or their supplemental benefit covering that 20%. So I'm using the numbers for the total under 16 patients for under the 1 hour. So under the 1 hour of DSMT, sorry, that's a typo there. And then when we look at group, for one person going through a group 9-hour program, it's $265 rounding up, and this is the total that we get. Now, Medicare also allows for diabetes 3 hours of medical nutrition therapy in the first year, and now we're not even talking about the follow-up annual follow-up visits that are allowed. This is just the initial education in the first year of the education. Nutrition therapy for 1 hour of individual, it would be the total for 16 patients going through a program, and then the group sessions, this would be 2 hours of group, and this could be divided up in any way. There isn't, all the visits could be individual. It's just a lot to get 16 patients through a program. We can do much more in a group session where we're covering a lot of the same information. So we see if we have 16 patients in a class, we can get upwards of 9,000 revenue generated for billing Medicare and in the state of Pennsylvania Medicaid for having 16 people going through a program. So this doesn't account for all of the back-end services that are required for billing. It's not necessarily an easy process. We need somebody that's managing the paperwork, submitting the claims, following up on claims that are not paid for, and making sure they're getting submitted properly, and keeping all those tracks, those things. So when we're looking at just the straight cost of running the program versus what the revenue is, this may look like a fairly high number for this type of programming, or maybe it doesn't look high enough, but we just need to take into account what it takes to get this billing accomplished. And then when we look at the per patient cost, it runs just generally around $580. Let's look at the health, behavior, and assessment interventions. I don't go into as much detail with this. I still need to go in and look at the actual, it's not broken down and easily accessible as the DSMT rate. So I can provide some follow-up information in our follow-up materials to the leadership group. But these are the codes that are available, and this is under more of a behavior model. So if we look at, this is based on any issue that is impacting someone with chronic disease. There is this health behavior assessment that is conducted. In this assessment, if there is anything that is impairing a person's ability to manage their chronic disease, regardless of the chronic disease, there is this qualification that can cover chronic disease self-management program. So we were talking about the DSMP program before. We know that there are many people that can go through the chronic disease self-management program as either a supplement after DSMP or before DSMP. So this is an opportunity to allow more support for individuals. So it tends to be reimbursed under clinical psychologists, social workers, licensed clinical social workers, physicians, and nurse practitioners. So this is another way to get reimbursement through offering CDSMP programming. And as I mentioned earlier, Medicaid peer services billing, this is an interesting element that's available in behavioral health. So there's a very structured model that we could look at, because one of the areas that I think we really need to explore is how do we incorporate community health workers into this model to support the intensive need across our state for self-management education. So these are peer, similar to lay leaders, so peer support specialists that are supervised by mental health providers, professionals. There is specific care coordination of the peer services, similar to the way Stanford's model is. There's lots of fidelity built into it. And there is ongoing training and certification, as well as if a diabetes program is accredited or recognized, there is a requirement for 15 hours of continuing education. So that could fall into this type of model, and it complements very well. So we could create a model in our state to potentially be innovative and test it within our state to see if we can utilize what has been done in the behavioral health world to the physical and medical clinical world. Other models in paying for these types of services, and again, I'm not going into extreme detail. I really would like to get the feedback from the group on what additional information is needed. What we can do is if there is a request for more information, we could certainly create a webinar recording that goes through some of these details and collects information from the group regarding these incentive-based models. So we have patient-centered medical homes. Patient-centered medical homes have incentives built in that if self-management education programs are offered, it improves the overall outcomes and allows costs to be controlled, as well as establishing the patient-centered medical home to be eligible for any incentives that are available. We have the health homes that are happening in our state. And again, this is on many levels, both the physical and behavioral health side. Community Health Choices is launching in Pennsylvania between July 2017 and 2019, starting in Pittsburgh and then moving its way across the state to the southeastern Pennsylvania region. And that is the combination of the long-term support services with the physical health side, so that we don't have a separation of managed care, managing health, and then on the other side, support services. There will be more of a coordination. And measures. There are incentives as well as controlling costs. Home and community-based services are what we operate under now, and there's several incentives and value for assisting patients in self-management under these resources. And then when we look at value-based care plans and care with MACRA and NIPS, there are multiple models for reducing. So as of January of this year, there are varying, what are they called? They are not incentives. Well, incentives, primary care providers and healthcare providers are incentivized to improve health outcomes, or they will be penalized, is what I'm trying to say. So under MACRA and NIPS through Medicare, And then there's the chronic care management model that can be both a fee for service and an incentive-based model, where we can partner self-management programs to help in chronic care management in supporting patients and allowing primary care and healthcare providers to recoup some of these dollars through the chronic care management model. So we could certainly spend a whole hour talking specifically about some of these areas, but I wanted to get feedback from the leadership group on which areas. I'm sure there are experts out there that might be able to speak to some of these models that we've discussed today or on this list, or if you would like to have a more detailed conversation about these. Okay. All right, so we have plenty of time for discussion and action planning. I want to open it up at this time. In the future, we're going to embed some questions into our presentation so that there can be some food for thought. But I open it up to questions, thoughts, input from the group at this time.
So I guess I have a question that I could offer up to maybe get the conversation started. Can everyone hear me? Or Gina, maybe you can repeat the question. Good morning, everyone. This is Kim with Health Promotion Council. Can everyone hear me?
Yes.
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 Yes. Thank you. Great. Thank you so much. So this was really good information to understand some of the nuts and bolts on the amount of investment a health system or provider would have to put out on a specific programmatic level, and the spreadsheet and so on. There was a lot of supporting tools that I think could be helpful. It could be helpful for an organization wanting to look deeper at their specific costs. And then some of the returns, it seemed like, were a little bit more national. And so one of the conversations I've heard among the NCOA group is how do we, and I'm hoping that the LSG members here may have encountered this and have some great ideas to offer. But one of the questions that I'm hearing is that a hospital or health system, they're weighing having to put out hard money today for a projected possibility of return later. So what do people think about making the case for, hard dollars today for that gray dollar or that green dollar tomorrow? Does anybody have any ideas? Maybe you're already experiencing or heard some of these conversations in the field, in your respective fields.
This is Marlon Williams from HPC. I'll chime in just not specifically relative to the CDSME conversation, but just overall when we talk about other evidence-based programming and other best practices being implemented. I think what's going to be critical, and as I was listening to Gina's presentation, which was fabulous, I think the information is really tremendous and really justifies, right, from a very broad perspective, the importance of this. But I think to speak to what you're speaking to, I think it's going to be important in convincing and conveying this to healthcare providers is our value proposition. So how do we translate all of this information? And I think that's going to be key, a key piece of the development of a sustainability plan to really effectively and in an impactful way convey our value proposition in a way that will translate down to that translates well down to the individual provider level, because this has got to be taken and it's got to be implemented it's got to be developed up here, but implemented at a very local level to the extent where the sustainability plan translates to the actual sustainability of an individual program provider like a AAA or even a healthcare provider who adopts this program. So how do we create that value proposition, and then how do we communicate it in a meaningful way to get buy-in from folks who are not just going to partner with us or with these programs, but even for I looked at the very first strategy around sustainability, to engage payers, right? To folks who are going to provide the support for this, which is why I'm really grateful for the managed care partners that we have on the phone, and would love to hear just their thoughts around some of this. But I think my response applies not just from the standpoint of engaging those health system partners, those payers, but also speaks to the work that we need to do in taking all of this information and translating it efficiently into the model or the plan. And we'll be talking about what is the model at some point. What does that model look like? But all of that has to like translate in a real meaningful way.
Is there anyone that is trying to speak that for some reason can't speak? If you can access your chat and let us know. Okay.
This is Tricia.
So I think
Can you
this
hear
is
me?
Gina. I know this is Gina, but I think in response to Marlon and Kim, thank you so much for your thoughts and your input. That is where that healthcare savings estimator, I think, will have a great deal of value locally, because it will give us information at the local level that we can go to hospitals, health systems, and plug in this information and run a pilot to say, look at the impact on your local community. I think when we start looking at community health needs assessments and how that ties into the needs there, when we look at one thing I didn't even put in here, we haven't even talked about, our HEDIS measures, where all the both primary care providers, health systems, as well as the payers are being measured against the HEDIS measures that are established nationally. So we know, and there's lots of push from the National Council on Aging to use those star ratings and the HEDIS measures as a way to promote how self-management programs can impact those measures and where they fall. So instead of looking at these programs as we can only utilize you if we have a direct fee for service, but really looking at how do we invest in these programs and bring them on as a partner rather than looking at just as a fee for service program. Because if we bring them in, we could potentially impact those HEDIS measures, improve those outcomes, and not even so long term. I mean, reducing hospital admissions and ER visits can happen pretty quickly in a person who goes through a self-management program.
This is another question. She says, it was not clear to me if the payers are being approached for pilot studies similar to what they did for NNP and diabetes.
So,
She said said, it was not clear to me if the payers are being approached for pilot studies similar to what they did for MNT and diabetes.
Specifically for this project, I think initially when we wrote the grant, that was the goal, which is why we engaged two managed care partners at the onset. And so really what the plan was a demonstration of an implementation of our program here in Pennsylvania, was to begin to kind of evaluate it, but also value the program itself as it was being implemented, and use that as a case study to present to payers. So with what's happened with the delay in implementing the program, there's a significant amount of time in building and developing many of the systems and the partnerships. We're just now getting to that place through the implementation of the program, and just getting to a place where we can begin to actually document, extract data, value the actual program, to make that very case. So that's the kind of a long yes, it will happen. That is the plan. We're just now getting to that place, and we'll be utilizing that to engage payers in that discussion, and in expanding those partnerships.
Does that answer Patricia's question?
If you can hear me, can you hear me? Oh.
Thank you for that question, Patricia.
And I guess
Okay,
if I may, one of the things, Marlon, this may have been encompassed in your response, but just to underline that the outreach work that the CLI project team has done has also been really working with referrers as well, as it really, those that are in our more traditional primary care physician type roles, but also looking at what role pharmacists could play in this, and non-traditional partners, because we understand that referrers are going to be really critical in maintaining the sustainability, whether it's happening in a clinical or a community-based session. So a lot of that work has been undertaken, as Marlon was saying, around that partnership development, and there is interest.
And I think I would take that one step farther, Tricia, with one thing that's important with studies for especially the Self-Management Resource Center work. The studies have been done. There's 30 years of evidence that they've compiled on outcomes. So what the Administration for Community Living is not funding, because the evidence is so strong, is that those ongoing studies. So while and that's one of the reasons why we are not specifically collecting clinical data through this program. We're collecting more of the resources or the information that Stanford or the Self-Management Resource Center requires us to collect, as well as the Administration for Community Living around the confidence. So if we can get people to the program, we know that it works because the evidence is there. So while we move forward in the state, I think one of the things that we would want to make a decision about through the sustain of our leadership group is if we do want to collect that clinical data as an ongoing part of assessing our successfulness and effectiveness. And then how do we get that data? We'd have to work together collectively to compile that information. Okay. More questions?
Is it okay, Gina, can we ask the group, both internal and within the wider LSG group, to to begin to think about what Marlon was saying, what we were probably going to need for the plan around the value proposition, so that we can sort of collectively bubble up some ideas around the marketing that needs to happen to do that translation, and then, bring those ideas to this forum and discuss and pull apart and build something that's going to be really unique and potentially successful in Pennsylvania. Is that an ask that would be okay?
I think so, sure. So we can use the chat box if you wanted to respond. Should we go through and look at our potential partners in this? So if we look at the top partners, so if we look at the value proposition for payers, would that be something that we would want to flesh out in establishing what that value proposition is for payers? So a yes, a no, maybe.
Yeah. No, I feel sick.
And then, we're still working on
Putting up on the weekend, dude.
partners involved that will support the ongoing implementation of these programs. So when we look at healthcare systems, they too are a very critical partner in this, both as supporting the delivery of these programs, as well as if they're an accountable care organization, we need to get their buy-in to help support these programs. So will they support staff that will be able to go out in the community? So that would be another area of a yes, no, thumbs up. Definitely we should move forward with looking at the value proposition for a health system or a hospital and what that would look like for them. And I would think that with the ACOs and the health system, we're also looking at their primary care providers. And we know that there's lots of demands on primary care providers, but this is something that will help them rather than use more work for them. It hopefully will actually make their job easier. So that would be, so if you think that that is an area that we should definitely move forward. Yes, we have a question.
My question, Melissa says, I agree. I think it makes sense to reach out to purchasers of insurance. Insurers are squeezed from all sides to reduce premiums. It's to Kim's point that it's hard money today for savings that might not be felt immediately.
Thank you.
Thank you, Melissa. I appreciate that. And where Gina was going to with kind of the value proposition being sort of that next phase of marketing, or one of the next topics is charged with covering in the area of marketing is if I may invite any groups that are currently working in this area, if there are stories and testimonials or different expressions that could be shared to make the case. I think I know from my everyday life, if I get a referral from somebody I know and can relate to, that goes a long way in demonstrating the value to me. Thanks, Jenny.
I'm listening to the background noise from the phone that's not muted. It's very hard to hear.
Oh, okay.
Yeah, thank you, Melissa. I hope this is a little better. What I was just acknowledging your comment, thank you, and what I was inviting everybody in the group to do is if you have stories or testimonials or you see something working, any kinds of expressions like those could really make this topic very relatable to both the payers and the health system players that Gina was just touching on. And I would invite us in whatever way feels comfortable to share share our collective experiences with one another so we can really build critical mass and make the case to those that will be pitching the plan, insurers and health system players alike. I think I'm looking now at our community living initiative coordinator for a question. We are collecting stories currently. Is that right, Ruby?
Yes.
Success stories of our work and our piloting. Okay. So that would be something that maybe we could include or discuss in the marketing piece.
And to address the background noise, it looks like there may be some individuals that are not muted. So if you are on the phone, if you can mute your phone just to make sure that there isn't background noise. We're not hearing it here. I don't know why, but thank you for that information. Sure. So what we can do is potentially in follow-up to this is provide a survey to you. Would that be the easiest way for you to respond to some of these questions, to get a group pulse on where everyone is and how we should move forward? Okay. So as we're working with sustainability and funding, this is an ongoing discussion because as we know, there's so much happening in the healthcare landscape with coverage. As we speak, we're waiting on changes to our healthcare programming across the nation and reimbursement. So we don't know what's going to happen. Hopefully we have more flexibility than less flexibility, especially at the state level. So we definitely have to stay flexible and knowledgeable and really be innovative as a group and partnering together to explore how can we best leverage what is available to us. With Person Link, Stephen Davis is at the table. We're talking about the intellectual disabilities population, and there's a push, and correct me if I'm wrong, Stephen, there is a push to help those individuals to be more independent and to become employed. Absolutely. So we're looking at that model and using some of the funding streams that are available to help support the training of those individuals that will bring in reimbursement and support for this. And then if we can work on the physical health side or the health behavioral assessment intervention side, that we can then support these individuals in being peers for their peer groups and providing this type of programming.
That's absolutely correct, Gina. This is Steve Davis from Person Link. Pennsylvania, as you know, is an employment first state, and the peer support model and just really being able to incorporate the individuals with intellectual and developmental disabilities into this system as peer support specialists in an employed fashion would go a long way to support the sustainability of this program, at least in Pennsylvania. Mm-hmm.
Gina, it's Melissa. Can you hear me?
Okay, so we will go ahead and please continue to provide us with suggestions on who we should invite to the Leadership Sustainability Group. We followed up on the recommendations from last call. Thank you for those. We will continue to add and share the recording and the meeting materials to everyone. If there are things that you want to make sure are covered in the future topics, please let us know. We are working feverishly to make sure that we have these materials in advance to be able to give to you for any feedback to make sure that we are covering information. I have a question.
Yes. Melissa is asking, the data is so compelling. Does it make sense to ask insurers their barriers to cover in the program?
Oh, that's a great. Thank you, Melissa. So maybe that's a question we can put out to the leadership group and see if we get some response from them that we can then incorporate into our planning and share with everyone. So if we can talk about meeting logistics and strategy, again, just to recap the way that we are performing this work, instead of getting everyone together and having travel expenses and hotel expenses and having a lot of those costs associated with bringing people together face to face. Of course, we prefer that, but since we are such a large state and people are working on multiple initiatives and this is a volunteer basis and we appreciate your time, we are trying to make it as efficient as possible. So we're utilizing this system of using virtual meetings and this conversation. Hopefully everyone feels comfortable with providing their input. We're trying to give you multiple avenues to provide your input, speaking up at the meetings, using the chat box, through the post-meeting survey. We encourage any of you who did not participate in the meeting survey at the first meeting to please go ahead and provide your feedback. We will be providing a follow-up survey to this meeting, as well as more promptly providing the recording and the meeting minutes and so forth. So if you have any suggestions on the logistics and the strategy, please provide that feedback also. One challenge that I had over the last couple of days is sharing the public Google Drive link so that even if you don't have a Google email address or account, you can still access the drive. I've received some feedback that those types of links are blocked by your organization. If you think it's possible for you to get access to that, hopefully that will work. If not, I did ask if individuals that were having that problem could use Dropbox. So if we could get feedback from everyone about using that cloud-based storage of this information so that we're not inundating your mailbox with large attachments. The other challenge that I had was zipping the files. I received multiple messages back that the zipped file would not pass through your security firewall, which is excellent to hear that your systems are not accessible and really keeping out potential hazards. So we just need some feedback on how to get that information to you in an easy way, easy access, and that's not, like I said, inundating your inbox. So I don't know if anyone did get the zip files. I tried to send the recording, the meeting notes, as well as some background materials on Pennsylvania Community Living Initiative, which included our flyers, our academic detailing packet, our PACLI overview that provides just a snapshot in about 14 minutes of what the program is about. So any feedback that you can give on that, we can explore that. We're also looking into whether or not we can utilize Health Promotion Council's website as a host for this information. So we're working on some of those technology issues. Okay, so unless there are more questions.
This is Caitlin. I don't know if, Gina, if you want to do this now, but we have two potential meeting days for meeting 4 and meeting 6. So I'm just gonna, I don't know, is that on a slide or? Mm-hmm. Okay, perfect. So
sorry for making you dizzy.
We can either, I guess, write in the chat or respond to us what you would prefer. Actually, for meeting 4, we have, I thought we also had Tuesday, July 18th from 10 a.m. to 12.
I think we just chose Wednesday the 19th. So,
okay, that's fine with me.
So we can send out
yes.
if anyone has a preference.
But for meeting 6, yeah, we have Tuesday, August 22nd from 10 a.m. to 12 p.m. or Wednesday, August 23rd, from 12 p.m. to 2 p.m. So if you have a preference for the day, please let us know. Otherwise, I think we will internally try and figure out.
Yeah, it looks like Heather's already making a note to herself that we're going to add that to the survey.
Yes.
So when you get the survey, you'll have some time to respond to that. And we'll add, the extra day in for meeting 4, or leave it?
It's up to you.
Okay. We'll go ahead and put the 18th back in and just see if there's more response for the 18th instead of the 19th. Thank you, Caitlin. Okay. Well, again, thank you so much for your time and the feedback that we received, the questions. This is excellent. We look forward to the next meeting where we're talking more specifically about what does this sustainable delivery network look like to support and sustain this programming beyond even the funding parameters that are required. So we look forward to having you all meet the other states that have been extremely successful in this work, and we'll be working on all the remaining meeting items as we move forward. So with that, again, not to make you dizzy, but if there aren't any, I'll allow another minute to have anyone ask any questions. Our next meeting is on Wednesday, July 13th from 12 to 2. We will be distributing the meeting recording and notes and sending any additional invitations from names and recommendations that you all provide. You are also welcome to forward the meeting invite to anyone that you wish to participate. Just let us know their name and contact information. We'll be updating the slides as needed. I wanted to update the reference list for everyone, and we will begin drafting the sustainability plan, incorporating some of the discussion that we had today for your feedback. So with that, I hope everyone has a wonderful day, the good rest of your week, and we'll be talking in a couple of weeks. Thank you so much.
Thank you.
Thank you. Bye-bye.